You're watching CTOM TV. Knowledge is power.
So another approach is looking at colon cancers based on their mutation scores. And there's a couple of different mutation scores that we can look at. One of them is called microsatellite instability. Microsatellites are little pieces of DNA. They're repeats that are located throughout the genome, and they're originally discovered and used in forensics and in paternity. So you can match people from the same family by their microsatellites. They have certain microsatellites that will match. And everyone who is unrelated, the microsatellites are different. So you can use these microsatellites to match people, and that's where they're first discovered. What we now know is there's a circumstance where people have a lot of variation in their microsatellites, and they become unstable. And these are referred to as MSI high. And so MSI high is a test that is often included with tumor DNA sequencing. And if you have MSI high, it means a class of drugs called PD-1 inhibitors, immune therapy, can be somewhat beneficial. And regardless of the type of cancer you have, if you have MSI high, PD-1 inhibitors can be very beneficial. We were the first to use PD-1 inhibitors in Canada. We've had some amazing results from them. They don't work in everyone. We've spent a lot of time trying to determine the molecular features that determine whether a PD-1 inhibitor will work in somebody, because if a PD-1 inhibitor works, then that person has a chance of what we call durable long-term remission. So in other words, a certain percentage of people that take PD-1 inhibitors will basically, their tumors will go away and never come back. And we have a variety of different patients that's happened to. Patients that were on death's door that had literally months to live. They got the PD-1 inhibitor, that all their tumors disappeared and have not come back in the last 5 to 7 years. So if you do have MSI high, then it's kind of like winning the lottery. There's also another condition called called TMB, which we're going to get onto now. And it's a similar thing. Often when you have MSI high, you also have TMB. TMB refers to the amount of mutations you have per 1 million base pairs of DNA. If you remember, the base pairs are those separate little connecting molecules in the DNA strand. So if you have more than 10 of these mutations per million base pairs of DNA, based on what's called the Foundation 1 tumor DNA sequencing test, then you have high tumor mutation burden, and these PD-1 inhibitors, these immune therapy drugs will work for you. The higher your tumor mutation burden, the better these drugs are going to work. So it's important that you know that both of these tests, MSI high and tumor mutation burden, are included with most tumor DNA sequencing tests. Okay, so immunotherapy. So as we just mentioned, if you have high tumor mutation burden or MSI high, then these drugs can work for you. However, most patients don't have this. Most colon cancer patients don't have this. In fact, we call this winning the lottery because it's only in about 3 to 5% of patients with cancer. In fact, the FDA has approved PD-1 inhibitors for anyone with any type of cancer that happens to have high tumor mutation burden. And so it really is a lottery. And it's the reason to get tumor DNA sequencing, because you just never know if you're going to win. And we had a patient win just last week, and it was just I was so happy to talk to the patient and say, you know, a big part of your problems are over. You're going to be getting an exceptional response to PD-1 inhibitors. And so it's a great, very important thing to get tumor DNA sequencing. However, most people won't have that. And so what can you do then? Does it mean immune therapy is not going to benefit you? Well, actually, what we're starting to find out is that we can imitate the MSI high and the high tumor mutation burden features by combining certain targeted therapies or chemotherapy drugs with immune therapy. So one of these drugs is called regorafenib. Now, regorafenib is a targeted therapy that was designed quite a few years ago. It's approved for colon cancers that have failed all other chemotherapy. But the problem with regorafenib is it's what we call a dirty kinase inhibitor. Kinase inhibitor is just a type of targeted therapy. The reason we call regorafenib a dirty inhibitor is because it has so many targets that it causes a lot of side effects. And because of that, most patients can't tolerate the standard dose where it's beneficial. So regorafenib, in order to be beneficial by itself, has to be given at a fairly high dose, I believe 160 milligrams. And most patients just can't tolerate that. They get too sick from it because it targets so many different off-label things that it's not supposed to. However, when you combine this drug, regorafenib, with standard immune therapy in patients that don't have the MSI high or the high tumor mutation burden, patients can actually get a response to it. It's obviously not as good as if you had those features, but you can still get significant benefit even after all of your other treatments have stopped working. So there was a study that was done in Japan, I believe by Fukioka et al. And they found out that the majority of their patients, I think it was like a 36% response rate. In other words, out of 100 patients, late stage colorectal cancer patients that got this regorafenib plus a PD-1 inhibitor called nivolumab, 36% of those patients responded, which is really good for late stage colon cancer because typically they're just going to give you the same chemotherapy drugs over that didn't work the first time. However, if you could just go back briefly to that slide. However, there's been a few other studies since then, and a recent study done in the States did not find the same results. In the American study, they found that the patients didn't actually, the patients who had liver metastasis didn't really respond, and the patients that had liver metastasis didn't respond, and the ones that did got a response that wasn't as good as the Japanese study. So we did an analysis of that because we had a lot of oncologists saying, that we heard that treatment doesn't work. That combination of regorafenib plus immune therapy doesn't work. There's a new study that shows it didn't work. So we compared the two studies. And what we found was they actually used different patients. The majority of the patients in the Japanese study had left-sided tumors, and the majority of the patients on the American study had right-sided tumors. And so, it was basically a slightly different disease. So what it's starting to look like now is that the immune therapy combinations, when you combine it with regorafenib or chemotherapy or other drugs, work much better in the rectal and distal, left-sided tumors than they do in the right side. And that's to be expected because really most things don't work very well in the right-sided tumors. And that's why focusing on right-sided tumors is a big part of our research too, looking into that. However, I will say that in that study, they found that the disease control rate was very good and similar in both studies. So the disease control rate is something based on what's called the RECIST criteria. The RECIST criteria is a way of determining how well a treatment worked. And it's broken down into 4 different, what we call responses. So in the RECIST criteria, you have what's called a complete response, and that's roughly where all of the tumors respond to the drug. You have a partial response where some of the tumors respond, but others don't. Then you have stable disease. And stable disease is the tumors don't shrink, but they don't grow either. And so that's an important consideration when you're dealing with the late stage cancer. Additionally, you have a negative response, which is referred to as progressive disease. And that's where the drugs don't work and the cancer keeps growing. So that's called the RECIST criteria. So what disease control rate is it's a combination of all 3 of the positive responses. So it combines the percentage of patients that got a complete response with the patients that got the partial response and with the patients that got the stable disease. And it gives you a number called the disease control rate. So in both studies, the disease control rate was really good. It was, at least 30, which is not bad for both studies. So it definitely does have some value in both sides, but we need to work more on that. For now, we're focusing it on left-sided tumors.
Thank you for watching CTOME TV. Subscribe below and stay informed.